We are live.
Good evening and welcome everyone to the DOS Postgraduate Education Program. Today we are on the 32nd lecture of DOS PEP, and as you all know, we are currently in the Retina module and we are running the 10th class of the Retina module. We are glad to have Dr. Vishal Agarwal with us, who's the speaker for the topic Degenerative Myopia that we are going to conduct today. We are thankful to Professor Rohit Saxena, sir, our president, Dr. Prafulla Marana, sir, the secretary of DOS, and Professor Kirti Singh, treasurer of DOS, for envisioning this program for the benefit of all the postgraduate and the DNB students who are watching this program all across the country and also beyond. We are also thankful to our chairperson, Dr. Lalit Verma, sir, who has designed this whole module of Retina module of DOS PEP and selected all the speakers and the topics that are relevant for postgraduates for their exam purpose. We are also thankful to Dr. Anupam Sachdev, sir, who has helped us to bring in the ANBI collaboration that brings all the DNB students on a common platform for this DOS PEP program. The speaker for our day is Dr. Vishal Agarwal. He is a postgraduate from the prestigious AIMS New Delhi. He has also done an FRCS from Glasgow, FASRS, and FACS. He's done a Vitro-Retina fellowship from Shankar Nethralaya, and he is currently the director of Agarwal Hospital in Jaipur. He is an ex-faculty from the Department of Ophthalmology in SMS Medical College, Jaipur. He has presented numerous instruction courses and co-authored books, published in index journals, and performed live surgeries at national and international conferences. He is on the editorial board of the Indian Journal of Ophthalmology. He has also been a principal investigator of various studies and has FDA-approved multicentric trials on AMD and RVO and uveitis. He has various awards to his credits and has won the AIOS Ophthalmic Hero of India Award 2017, 2021, Best Surgical Video Awards and Best Photograph Award, and few awards by the American Society of Retina Specialists in 2023 as well. So with that note, sir, we welcome you, and we also have our secretary, Dr. Prafulla Maharana, sir. And sir, a few words from you before we move on to the class.
Thank you, Pranita. Thank you, Vishal sir, for agreeing to take this lecture. And just to clarify, a lot of students are asking where to watch this. See, for students, you have to register for the Tech, and then you can watch through that YouTube platform. For the viewers, those who just want to watch, you can log into, or you can just check in our YouTube channel of DOS. There you can watch it. And I welcome you, sir, for this DOS PEP. And Pranita, let's go ahead with the lecture.
Yes, sir. So you can share your slides.
Sure. Can you see my full screen? And am I audible?
Yes, sir, both.
So at the outset, I would like to, thank you, Delhi Ophthalmological Society, Rohit sir, the president, Praful, the dynamic secretary, Pranita, Lalit sir for envisaging this program. It's actually an honor and pleasure to be associated with such a great PG teaching program, which they have called DOS PEP, Postgraduate Education Program, in association with ANBAI. So with that, I'll be speaking on the topic given to me, that is degenerative myopia. So there's a lot to sink in about this topic, and it has a lot of controversies and a lot of definitions and a lot of features also. We'll try to sort it out in the coming 30 minutes or 40 minutes as clearly as we can. So the outline of the presentation will be some basic definitions and some anatomy and a brief introduction about myopia and its a severe form, that is pathological myopia. Some basic sciences very briefly associated with this condition. And the most important part is the third point, that is the clinical aspects of this severe form of myopia. And of course, the what the future holds for us in the treatment of this disease, the research, the treatment available currently, and the future perspectives. So coming to myopia. So there's a lot, there's a lot of things in myopia, and it's beyond the scope of one lecture to cover everything about myopia. So our presentation will be, actually directed towards the more severe form, that is pathological myopia. But just for the introduction sake and for a brief opening, myopia, as we all know, is a massive public health issue at present, causing significant visual loss in young people, and it is a risk factor for other ocular comorbidities also, like glaucoma, retinal detachments, etc. And as we all know, especially after the COVID pandemic, we as clinicians see day in and day out in our OPD the huge amount and the huge increase in the magnitude of the prevalence of myopia. Every third or fourth child who is coming with a refractive error is coming with a -1 or -2 dioptric refractive error, which was uncommon before the pandemic. So the prevalence is increasing on a global basis, we all know. But the reasons, there are some hypotheses, there are some conjectures, but there is no proven reason. And so it's not understood exactly what is the pathogenesis of a certain outburst of myopia in the population. So coming to the epidemiology, we all agree on one point, that it is different in different regions of the world. So the general population, 20 to 80% has a myopia prevalence, but that's a very high range. So historically in East Asian countries like China, Taiwan, and Japan, it's very high. It's almost 80%. Whereas in India, it is around 15 to 25%. And the high myopia incidence among the myopia is around 9 to 11%. And further, if we divide it into pathological myopia, in India, it is around 1.5 or 2% in school-going children. And the average is 1 to 4% of the world population. But by the rate of increase of myopia, it is estimated, as you can see in the picture also, that half the world population will have myopia by 2050. So that is the quantum of the magnitude of the disease, and by which rapidity it is moving ahead and causing a huge disease burden. And what are the reasons? As I said, nothing is proven, but what is proposed is the lifestyle, near work on your smartphones, on your tablets, and less outdoor activities, and of course, genetics. And genetic susceptible people are more at risk for this near work, less outdoor, and more smartphone time to develop into myopia, high myopia, or pathological myopia. So, as I mentioned in my first slide, historically, there had been many definitions of myopia, depending on the etiology, the cause, the age of onset, like childhood myopia, adult onset myopia, or axial myopia, or physiological myopia. As you know, according to the structural complications like degenerative myopia or progressive myopia, and the amount of myopia, the magnitude, whether it is low, medium, intermediate. But these all definitions lack uniformity and are not good for any statistical analysis or a research study point of view, and not also good for a common platform discussion. So the generally accepted definition is as per the diopters or the axial length. So myopia in general consensus is considered to be a refractive error of an eye, which is more than 0.5 diameters when ocular accommodation is relaxed, and that is the generally agreed definition. And coming to high myopia, the refractive error is from 0.5 to 0.6. Myopia is 0.5 to 0.6, and anything above 6 diopter is categorized under high myopia, or axial length of equal to or more than 26.5 mm when again ocular accommodation is relaxed. So myopia is 0.5 to 6. High myopia is more than 6 diopter. Now coming to degenerative myopia or pathological myopia. So of all these terms, myopia, early myopia, high myopia, this has clear-cut consensus in which it has gained a degree of international consensus. And this is by this huge study group, meta-analysis for pathological myopia, the META-PM study group, which has actually collated all the data, the longitudinal study of these eyes. How do these high myopic eyes progress? How do these degenerative changes whether they are stable or whether they progress or they further carry or they reverse in the disease pathogenesis. So it actually is not degenerative high myopia. So degenerative high myopia, the topic given to me, implies that this myopia and the complications associated with such a high myopia is because of degeneration. But we all know that these findings, which we find in pathological myopia, are like staphyloma, are atrophy. So atrophy can, come under the category of degeneration. But the other things like myopic CNVM and staphyloma, they are pathology and they are not because of degeneration. They are because of the outpouching of the sclera. So degenerative myopia is a misnomer, and actually pathological myopia should be the term which has to be used in discussions. Actually, interestingly, what my hospital software says, which is based on the ICD, International Classification of Disease, is when I type pathological myopia, nothing comes up. But when I type degenerative myopia, and this is by WHO, it comes up as these codings. And even the ICD-11, the latest version by WHO, also has degenerative myopia. So the Meta PM consortium, which I have talked about before, has proposed to the World Health Organization that pathological myopia should be, should replace degenerative myopia in the future amendments and the future versions of ICD-10. So we'll be using the term pathological myopia in this presentation. So by definition, pathological myopia is excessive axial elongation associated with the myopia that leads to structural changes in the fundus, in the posterior segment of the eye, which includes staphyloma, which includes myopic maculopathy, which includes optic neuropathy. And that can lead to a loss of best corrected visual acuity. So the definition has no confusion. It is absolutely clear that it is not related to the diopters. So a high myopia, a very high myopia cannot be a pathological myopia. Pathological myopia is based not on diopters, it is based on the structural changes in the posterior segment of the eye, like staphyloma. And what causes it? They can be, it is basically the prime pathology is axial elongation, which causes chorioretinal stretching, thinning, RP atrophy, and of course, there is a retinal defocus. So when there is a retinal defocus, there are structural changes in collagen because of the molecules released by the RPE and the outer retinal layers, so that there is axial elongation as well as outpouching in the form of staphyloma. But all these are presumptions. We do not know why high myopia is converted into pathological myopia in some individuals, whether it stays as high myopia without any structural changes in some others. So coming to the most important important discussion, clinical aspects. You as postgraduates, of course, should know the anatomy and the terminology and the definitions. But the most important thing is, because this disease is very common in your clinics, and you should know how to diagnose, you should know how to prognosticate these cases and how to treat these cases. So coming to the clinical aspects, the first thing is posterior staphyloma. So posterior staphyloma is the hallmark of pathological myopia, and it causes the most severe form of vision loss in the form of myopic maculopathy. That is the changes that occur in the macula of high myopic eyes. And what it is an outpouching of a posterior fundus region, and it is not just axial elongation. So just keeping that in mind. When there is an outpouching in addition to the axial elongation, that is called staphyloma. So how do you define it? It has the radius of curvature of any circle. So if there is an axial elongation, that radius will be longer than the radius of curvature of the staphyloma. I'll show you it in a diagram. And it, again, as I said, it should be differentiated from simple axial elongation, which is commonly seen on the OCT and the fundus photography of highly myopic eyes. So see this, pic. The first is a normal E-metropic eye, you can see. The B photograph is the axial elongation, and you can categorize it into high myopia. Okay. Now, if you presume and you take that dotted line and complete it as a circle, and this double arrow line is the radius of this circle, and let's assume it is R1. So this one The third photograph is C, and you can see this outpouching here. And again, you draw a small circle, and this is R2, the radius of curvature of this small circle. Now, this R2 will always be smaller than this R1. So the staphyloma is a specific outpouching of the eye, and it has a different radius of curvature, which is smaller than the radius of curvature of the whole eye. So this should be differentiated from a simple axial elongation. There are many classifications of staphylomas as per the location. The most commonly accepted classification of staphylomas is being given by Curtin, and grossly it is categorized into 10 categories, but the first 5 are important as per the location. The type 1 involves the whole macula, and the type 2 involves the macula but in a small magnitude. Type 3 is around the disc and is known as peripapillary staphyloma. Type 4 is nasal. Type 5 is inferior, and you can go through that in literature and in your books. We will not go into detail. But the importance of this classification is that it prognosticates again the visual acuity and the progression and how much the vision patient will have in the future or has currently. Some other classifications have also come up on the basis of the 3D reconstruction of the eyeball through the MRI, and of course to the latest imaging technologies like wide field OCT and wide field photography. So this is a 3D reconstructed, model of the eye showing the outpouching from the side and from the inferior view. So this also is, this can also be used for your understanding, but the most common is what I told you is the Curtin classification. So coming to real world cases. So as you can see, this is a fundus photograph on the left side and the OCT on the right. If you look closely, actually staphyloma is a diagnosis, is a 3D diagnosis. This is a 2D photograph. So you can't see the actual curvature dipping in. But if you look closely, this is the left eye, of course. And you can see the staphyloma is a peripapillary staphyloma. You can see the vessels are dipping here. And if you see a 90D or a 20D examination with the IO, you will see it very clearly. But just grossly, you can imagine that this is the staphyloma. You can see the margins here from the normal retina to the, with the CRA, chorioretinal atrophy, and the dipping of the vessels here, here, here. But the point I want to make here is this staphyloma is just sparing the fovea. So even this is a pathological myopia eye, and it has a staphyloma, but you can see that because the fovea is spared, the visual acuity will be good, as proven by the OCT on the right side. You can see the OCT till here is fine, all the layers are intact, the outer retinal layers are intact, the choroidal thickness is quite good. Now, if you see the curvature is going down, 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 down till here. So here the staphyloma starts, and it has luckily spared the fovea, so the visual acuity is good and will stay so. Now, coming to this photograph, this is again extreme case of pathological myopia. You can see a lot of chorioretinal atrophic patches in this yellow, yellowish appearance. And this is the color photograph. On the right side is the red-free photograph of the fundus of the right eye. And again, this part of staphyloma is the type 1 Curtin staphyloma, which is involving the whole of the macula. And you can see the difference between the curvature, the vessels dipping, of course, more clearly visible on an indirect examination. But the point again I want to make here is that here the staphyloma is involving the foveal center, and all the myopic degenerative changes like atrophy, macular atrophy, and loss of outer retinal layers are there at the fovea. So even the retina, even in this eye, even with full correction of the spectacles, the patient will have very poor vision. As you can see, the OCT, which is down here, is showing loss of all outer retinal layers and choroidal thickening. The vision was extremely poor, around finger counting 4 meter, as opposed to 6/9 vision in the previous slide of this patient. So coming to the second part, that is the most common terminology we use in myopic patient, that is chorioretinal atrophy. Now, chorioretinal atrophy is a very generalized and non-specific term. We write in every case chorioretinal atrophy. But as postgraduates, you should know what is the definition of chorioretinal atrophy as per the location, what is the prognostication, and what are the different types of chorioretinal atrophy. So this is the most common type of myopic maculopathy, known as myopic macular degeneration, and various classifications historically have been proposed, again, of chorioretinal atrophy. Now we are right now based, we right now follow the meta-PM classification of myopic maculopathy, and that I already told you is based on the longitudinal study of these eyes and meta-analysis of many other studies, and compiling all the data and forming a standard guideline. So that includes category 0, which means that there are no macular lesions. Then there are 4 categories. Category 1 is tessellated fundus. Category 2 is diffuse chorioretinal atrophy. Category 3 is patchy chorioretinal atrophy. Category 4 is macular atrophy. And there are some other additional features which have been included and called as plus signs, like Lacquer cracks, choroidal neovascular membranes, and Fuchs spots, and they can be added to any category with or without the involvement of the prime pathology. So if you look at this table, any category equal to or greater than category 2, that is diffuse chorioretinal atrophy and above, like category 3 and category 4, these are included in pathological myopia. Tessellated fundus per se is not included in pathological myopia. So coming to category 1, and why is it important? So category 1 is tessellated fundus, and also known as tigeroid fundus, that is tiger-shaped fundus, tiger-looking fundus. It is, appearance of well-defined choroidal vessels, which can be observed clearly around the fovea. And these are the first signs of high myopia, and progression can be expected if they appear in very young patients with -1 or -2 or -3 diopter of myopia. So they are often observed in children with myopia, and they are a harbinger of pathological myopia. Not necessarily they will convert into pathological myopia, but these eyes are high risk and they have to be observed. And fortunately for us, a tessellated fundus per se, without any posterior macular changes, will not affect vision. Most of the tessellated fundus without pathological myopia have 6/6 vision, unlike other lesions of myopic maculopathy. Just 2 photographs to show you. The left side photograph is of an emetropic eye, and you can see the bright, foveal reflex, and you can't see the choroidal vessels very clearly except in the far periphery. Now, if you go to the second photograph on your right, this is a patient without pathological myopia. The refractive error is around -4 diopters. This is the left eye, and you can see the shiny reflex has gone. And are the early changes of conversion into high myopia and consequently pathological myopia. And you can see all this orangish hue, these wavy lines, these are all choroidal vessels. And this is because of the generalized atrophy or thinning of the RPE and the loss of pigments, because of which all these choroidal vessels which are beneath the retina are visible. You can even see the vortex vessels. So this is a perfect example of a tigeroid or a tessellated fundus without any pathological changes, with preserved good central vision. As opposed to this photograph, this again is a left eye of a patient of pathological myopia. This patient might have a fundus appearance, as I showed you in the previous slide, maybe in his childhood. You can see all the choroidal vessels again visible, but now all the pathological changes have set in this eye. There is a posterior staphyloma, there is a scarring in the central area, and there is a diffuse chorioretinal atrophy in the center with very poor visual acuity. So this tessellated fundus, along with pathological changes at the posterior pole, will have poor vision. Coming to category 2. Category 2 is diffuse chorioretinal atrophy. It is a poorly defined area appearing yellowish white, and it varies from area under around the optic disc and the part of macula to the entire posterior pole. So it can be a peripapillary area of atrophy. It can be just involving the macula. It can involve the whole posterior pole. So accordingly, it is subclassified into peripapillary, diffuse chorioretinal atrophy, or macular chorioretinal atrophy, but diffuse. So if you see very closely the OCT, the choroid is absolutely thinned out in these cases and maybe absent in some sections also. And because of that, the larger choroidal vessels can be observed through the retina. But the important point again here is why is it kept in category 2? It looks by this definition, it is very severe. But the RPE layer and the outer retinal layer in these cases are very frequently preserved. Even if the choroidal layer is absent or thinned out, the outer retinal layers are there. And surprisingly, as opposed to the appearance they make, because of the preservation of outer retinal layer, the vision is decent in these patients. So coming to examples, this is a patient. The left side fundus photograph is a patient with the diffuse choroidal atrophy, and you can say that it is peripapillary. This is actually the left eye. The fovea is here, and you can see it's sparing the fovea. So we'll assume that this, of course, will have good vision. But if you see the right eye of this patient of some other patient, and you can see there is a peripapillary crescent, there is some patchy atrophies, these white ones, and if you see the whole macula is involved with choroidal atrophy. And this is, the margins are not very well defined. It is, yellowish white, as I told you before. The margins are undefined and it's a diffuse area of choroidal atrophy. But surprisingly, the vision in both the eyes is quite similar. That is 612, 6-9 parts. Why? Because now you see the OCT of this patient, which has a macular involving diffuse chorioretinal atrophy. And you can see the foveal dip is okay, the retinal layers are intact, and the most important outer retinal layers, the EZ and the ellipsoid zone, are grossly okay. And that explains that even with such a dull looking and a diseased looking fundus photograph of the right eye, the vision is quite good. Now coming to category 3, that is patchy choroidal atrophy. And this is a severe form of the choroidal atrophy, which we saw in category 3. These have well demarcated borders, they are grayish white, the sclera is visible through them. And because now in this, of course, the choroid is absent. That was absent in the diffuse chorioretinal atrophy also. But here, the outer retinal layers, that is the RPE, the EZ, and the ellipsoid zone, are also absent. In addition, you can identify them because the vessels will be, coming through them. The choroidal vessels can be visible. There can be pigment clumping. They are very sharply demarcated. If you do a fundus fluorescein angiography or a ICG, they are areas where there will be no choroidal vessel. So the choroidal filling defect will be there. And if you do a autofluorescence is dependent on the pigment fluorescence. That is the pigments in the RPE. As there is no RPE, there will be no autofluorescence. So the fundus autofluorescence will show a hypoautofluorescence in areas where these lesions are. And these are areas of absolute scotoma. And because obviously because there is nothing there is just the sclera there, and there are no photoreceptors within this atrophic area. So this is a very severe form of chorioretinal atrophy in pathological myopia. Coming to examples, you can see the right eye of this patient, and this actually has a diffuse chorioretinal atrophy also. Sorry. And within this diffuse chorioretinal atrophy, we can find this, well demarcated patchy areas, which are known as patchy choroidal atrophy. Now, if you come to the second photograph, this is a more severe form of the right eye, and it seems that these lesions, which were like in the right eye, have collapsed. Now, all these patchy chorioretinal atrophy patches have now joined in to form a diffuse area of well demarcated, where as I told you, by definition, you can see these choroidal vessels visible, you can see these black pigments over it. And actually this area does not have any RPE, only the sclera is there is no photoreceptors, and these both patients have very poor visual acuity as compared to the diffuse choroidal atrophy, with the visual acuity was quite decent. So patchy chorioretinal atrophy is a very severe form of myopic maculopathy related to pathological myopia. These are the OCTs of these fundus photographs. You can see Just the inner retinal layers are there, the outer retinal layer and the sclera is actually opposed, and you can't make out any choroid in between because of the atrophy. And again, it all depends, where whether you're lucky or not. So if the patchy atrophy is the fovea or the macula and they collapse, they will cause a loss of vision. But in this eye, you can see this is a diffuse macular chorioretinal atrophy at the foveal center. And there is also these spots of patchy chorioretinal atrophy, but they are at the edge of the staphyloma. They are outside the arcade, so they will not affect the central vision in this case. So this lady, when we saw this fundus photograph, we thought she's lucky because the most severe form of degeneration is outside the arcade, whereas the less severe form of degeneration, that is the macular chorioretinal degeneration, is at the center. Coming to the last category, that is macular atrophy. It is, well demarcated grayish white atrophic lesions on the fovea. Again, these are total atrophic areas. The feature, they are well demarcated, almost similar to patchy chorioretinal atrophy. The main difference is it involves the central fovea, whereas the patchy chorioretinal atrophy are generally parafoveal or outside the arcade, but if they coalesce, they might involve the central fovea. So choroidal neovascularization, secondary to pathological myopia, when they cause scarring, it is known as Fuchs spots, and the last stage is atrophy. So it's all a spectrum. So first, a neovascularization develops in the fovea. It converts into a scar, which is known as Fuchs spots, and the Fuchs spots, actually go into macular atrophy. And but unfortunately, if a patient has a foveal involving macular atrophy, these eye have generally very poor visual acuity, less than 0.1 in eyes with macular atrophy. These are a few examples. You can see the fundus photograph, you can see the OCT, everything is gone here. You can see the choroidal vessels, you can see the myopic CNVM, which has actually scarred and caused atrophy. There is again a very thin layer of choroid and very poor visual acuity. Coming to the plus lesion, the first is lacquer cracks. If you might not have picked it up in routine examination, but if you know what it is, it actually carries a lot of significance. So these are horizontal or vertical lines, crisscrossing lines, and they denote basically the breaks and subsequent healing of the Brooks membrane and the choriocapillary complex. And generally they are horizontal, but they can be vertical also, and causing that crisscrossing pattern, and very beautifully picked up in multimodal imaging. ICG, indocyanine green angiography, it appears as a linear hyperfluorescence, and as it is a break in the RPE and the Brooks membrane, there will be a window defect corresponding to the lacquer crack. So if you do a angiography, a fundus fluorescein angiography, because of the window defect, it will cause a hyperfluorescence. And if you do a autofluorescence, again, there is no pigment over that area, so it will cause a hypoautofluorescence in the area of lacquer crack. Now, the clinical importance I'll come to later, but generally lacquer cracks, do not cross the central fovea. So they have patients having lacquer cracks without a macular scar will have good central vision. So I'll explain it more convincingly with a photograph. You can see this is a high myopic patient. You can see the tigroid, the tessellated fundus, and all these choroidal vessels. And you can see all these crisscrossing lines, which are breaks in Brooks membrane and the RPE and the choriocapillaries, which have healed, and they are horizontal, they are vertical, and this is what a lacquer crack looks like. And I was saying about the fundus photo, this lacquer crack, again, the fovea has been spared. This is a very thick lacquer crack. If you see the OCT, there is hyperreflectance because the light of the OCT will, transmit more, and you can see a back scattering. So this is the area of the lacquer crack here on the OCT. And the third photograph on the left downside is the fundus autofluorescence, and the fundus autofluorescence will be black. This whole line is black because of absence of pigments here. So this is a confirmatory diagnosis of a lacquer crack. Coming to the second plus lesion, that is the myopic CNVM, very important clinically, very important because this is something which we can treat. So a myopic choroidal neovascular membrane presents with blurring, scotoma, metamorphopsia. These patients are young as compared to the age-related macular degeneration having a secondary choroidal neovascularization. And how do you diagnose? Of course, the patient can be young, will be young, and alongside with the choroidal neovascular membrane, there will be the other signs of pathological myopia. That is chorioretinal atrophy, whether diffuse or patchy, or staphyloma might be present. It appears as a grayish subretinal lesion. Not much of fluid as compared to ARMD is there. Not much of hemorrhage is there. Not much of exudation is there. And OCT picks this lesion very nicely, and it appears as a very highly reflective subretinal hyperreflective area above the RPE. So if you have read the classifications of the type of choroidal neovascularization membrane, type 1 is below the RP and type 2 is above the RP, even in ARMD. So these classify as a type 2 MNV, myopic neovascular membranes, because the hyperreflective area is above the RP. The subretinal fluid is very, very minimal. The angiography in all classical membranes, as well as in these cases also, there is a definite well-defined hyperfluorescence in the early phases, which increase with fuzzy margins in the late phase. And recent technology has enabled us to perform OCTA. OCTA is OCT angiography. This is a dye-less thing in which without a dye, you can, see the blood vessels, the choroidal blood vessels, the retinal blood vessels. It's not a dynamic scan, but it shows you all the vessels without invasive procedure as a dye. And they can detect all the vascular network in a myopic neovascular complex. Of course, if it's a very small complex, the OCTA, that is OCT angiography, might miss it. So coming to the clinical photographs, this is a myopic eye. You can see this hyper-reflective area here and the associated SRF, that is the subretinal fluid here. So this is a myopic CNVM along with the fluid. If you do an angiography, you can see this is the well-defined myopic CNVM with early hyperfluorescence and which increases in size and intensity with time, as opposed to the occult membrane with stain late. So this is a classical type 2 membrane, and this is a branching network of the same membrane on the OCT angiography. And these machines have a different sections where you can manually segment them. This is the choriocapillary segment, and you can see the anastomosing lesion, the vessels here, depicting activity in this lesion. And this is a definite indication for treatment with anti-vascular endothelial growth factors. Now, what is the differential diagnosis? There can be many differential diagnoses, of course, but the most common and most commonly misdiagnosed is a simple bleed. So as I told you, lacquer cracks. Lacquer cracks generally are breaks in the Bruch membrane. And when this break happens, they generally heal and nothing is found at the healed stage. But when there is a fresh break, there might be a bleed. And this is the lacquer crack bleed. And they can be misdiagnosed as myopic CNVM, which actually they are not. So myopic CNVMs can develop through that break in the active stage, but if the lacquer crack heals, there will be no membrane coming out through that healed or fibrous lesion. So this was the right eye. You can see this bleed because of the lacquer crack break. This is the fundus angiography. As opposed to this angiography, you can see there is a hyperfluorescent lesion. Here there is a dark lesion because of the bleed, and it is known as the blocked fluorescence. And if you wait and do not inject, of course, the OCT will also not show any hyperreflective area. And this has resolved over 3 weeks without any treatment. So FFA, the simple macular bleeding appears at block fluorescence. And on OCTA, there will be no network and it will gradually resolve. And there is no need of injecting anti-VEGF. And there are many trials which have conclusively demonstrated that anti-VEGFs are very effective, and the number of injections required for myopic CNVM are generally less, which are required in ARMD. The standard of care is ranibizumab, aflibercept, and they're all been FDA approved for this condition. So standard of care for myopic MNV, which is one of the few lesions of this spectrum of diseases, pathological myopia, which we can actually treat in the early stage, is the use of intravitreal anti-VEGF therapy. Coming to the third and the last plus lesion, that is the Fuchs spot. This is the pigmented spot. As I told you, it's a spectrum. First is the myopic neovascular membrane. Second is a scarring known as the Fuchs spot. It causes the scarring phase of myopic choroidal neovascularization, and the RP grows over that lesion and causes pigmentation. And finally, it flattens, reduces in size, and causes a macular atrophy, which is type 4 of the classification. So again, you can see this is a scarred myopic CNVM without any fluid. I'll just go back. This was the hyperreflective area with fluid with activity. And this is the hyperreflective area with scarring and no activity, categorizing it as Fuchs spot. That is the scarred myopic CNVM, basically. So this was the features of the classification by meta-analysis, the MET-PM group. Some additional features are also very important and are recently in vogue. One of them is the MTM. And what we were right now seeing was the fundus photographic picture and the features of myopic maculopathy, of pathological myopia based on the fundus photographs. But because of the advent of OCT and SGOCT and the swept OCT, now we are more wiser about the finer features of the outer retinal layers and the inner retinal layers in pathological myopia. And one of the features is MTM, that is myopic tractional maculopathy. Most first described, I think, in 2008 and 9. It includes a variety of pathology because of the tractional forces over the inner retinal layers, and it constitutes epidental membrane, laminar holes, and other conditions. And finally, convoluting into foveoschisis, which is known as myopic foveoschisis, which is very, very unique to pathological myopia. It's very important to learn it. And these myopic foveoschisis generally progress to neurosensory detachment, finally macular hole formation, which can lead to retinal detachments. So retinal detachment arising from a macular hole is a very typical complication and a progression from myopic foveoschisis and only found in pathological myopia. And for all these jargons, OCT is very essential to analyze and make accurate diagnosis. And of course, these are all in the later stages surgical cases, so it helps you in your surgical decision making. So the surgical options are vitrectomy and macular buccal. So this is just one example of foveoschisis. Foveoschisis means the splitting of the foveal layers, the inner and outer retinal layers, and these are the retinal bridges which is holding them apart. And it progresses, causing a foveal neurosensory detachment. The bridges are thinned out. Further traction with the ERM and the ILM is there, which actually causes a lot of fluid and causes a full thickness macular hole. So these are the progressive changes. Barbara Parolini from Italy and their group have done extensive work in myopic tractional maculopathy, and they have classified the terminology in 4 categories. The first category is it is as per the increase in the perpendicular traction. So it starts from inner macular schisis, the macular schisis, and the whole detachment is the third category. And of course, with the Shiatic component, and the whole detachment without the Shiatic component is category 4. And all these 4 categories culminate tangentially to a macular hole. So you don't need to memorize all these classifications, but you should know that myopic tractional maculopathy is a very important part of pathological myopia, and not every pathological myopia needs to be the not every myopic tractional maculopathy needs to be treated because these are difficult eyes. The surgery in these eyes is very difficult. If the patient is coming with such a picture, that is myopic tractional maculopathy, and the vision is stable for the past 1 or 2 years, you just need to observe. Okay, there are many surgeons who will say, especially the Japanese group, they operate very early. But these can lead to complications. The surgery can actually result in a poor vision than it was pre-op. So you have to observe, and if the patient says and documents that there is a decrease in vision, there is a formation of macular hole, there is a formation of traction, then you go inside and operate. So like in the third photograph, there are 2 options. You can relieve the traction by doing a vitrectomy from inside, or you can push up this staphylomatous part and relieve the traction with the macular buccal. So vitrectomy, macular buccal, or a combination of both the treatment of choices. We'll not go into the details because as postgraduate, this is out of the scope of your curriculum. Some other additional features, dome-shaped maculopathy, again recently documented about 2 decades before. It's an inward bulge of the macula, and it is actually not detectable on fundus examination, and it's basically a OCT diagnosis, and it is a convexity in the concavity of the eye. So basically, staphylomatous area or an axial elongation of the eye causes a concavity of the contour. This is a convexity counteracting that concavity. And there are certain types of it. And the main complication is the presence of fluid, which is waxing and waning. It might decrease or it might increase. So this is a OCT picture of the dome-shaped maculopathy. You can see the dome shaped with the counteracting the concavity of the high myopic eye. You can see the subretinal fluid, and this is not CNVM related fluid. This is not CSR related neurosensory detachment. So there is no point in treating it with anti-VEGF or laser. This is simple dome-shaped maculopathy. The fluid can go or increase also in due course, but no treatment is required. Generally, have preserved good vision if atrophy does not set in these eyes. So, dome-shaped maculopathy, you should all know that it is an OCT-based diagnosis, not a 90D-based diagnosis. Last thing is glaucoma. We all know that there's a high prevalence of glaucoma in these eyes, can reach up to 50%, and detection is very difficult of multifactorial reasons because the refractive error is very high. Most diagnoses do not work. The fields are unreliable because of the peripapillary crescent, and the detection of optic nerve damage also gets very difficult in these eyes. Perimetric defects, as I told you, are unspecific, but you have to keep a strong vigil in these eyes. As you can see, this is a near total cup in both the eyes, and because of the peripapillary atrophy and the high refractive error, the fields have always been unreliable. And because of the thin pachy, these come with normal IOP, but if you adjust it according to the pachymetry, the pressures are high, and this patient is on 3 anti-glaucoma drugs. So again, we'll not discuss glaucoma into much detail. The final thing is, of course, lattice degeneration and breaks. We all know that these eye, the 30% more prone to have lattices as compared to 5% in the general population. Multiple lattices can be there, horseshoe tears can be there. So every examination, you have to be careful and meticulous in examination. See the periphery in these eyes, laser them. So this is a lasered lattice and multiple holes in an eye which has a posterior staphyloma. Coming to retinal detachment, there are two mechanisms of retinal detachments. These eyes, pathological myopic eyes, are almost 5 to 6 times more prone to retinal detachments as compared to normal eyes. And there are two mechanisms. First is the routine breaks, which can occur, or giant retinal tears. The left side photo is of retinal detachment in a pathological myopia having axial length of more than 30. And after surgery photograph is on the right side. You can see the posterior staphyloma, the macular scarring, but the retina got attached and the patient has navigational vision. So this was related to a large tear. The second mechanism by which retinal detachment occurs in these eyes is a macular hole. So if you see closely at the center of the left side photograph, there is a RD, and in the center there is a myopic macular hole. Now normally macular hole does not called RD in emetropic eyes, but in myopic eyes, below the macular hole, the retinal pigment epithelium is actually very diseased. So the chytic fluid when comes inside through the macular hole is not absorbed by the RPE, and only these eyes, that is pathological myopic eyes, can develop RD confined to the posterior pole or confined to the whole fundus just because of one hole which is at the macula. So here we did a vitrectomy and we had to close the hole to achieve success. And the right side fundus photograph is of attached retina after surgery, after silicone oil removal with a closed hole. Well, just for completing the program, just a small how we do the surgeries. There's no need to go into details of these things, but just a small clip. Second, sorry for that. So this is a high myopic ICL has been done. You must be all knowing how ICL should look and what are the challenging, facing these eyes. These eyes are actually 30, 31 mm. And the normal instrumentations are made for eyes which are 24, 25, 26 mm. So, special special forceps, which are actually longer than the conventional forceps, have to be used. And sometimes you have to make these ports, these pars plana ports, around 4.5 or 5 mm from the limbus. Normally we make it 3.5 or 4. But just to reach the posterior pole, the macula, we have to make them a little posterior, and we might have to make a direct entry. So the ICL is in place. The patient had a macular hole. The patient had a retinal detachment because of that macular hole. And now you can see we are doing a vitrectomy. Just a small clip just to show the procedures, the steps of this complex surgeries. We stain it with triamcinolone acetonide. We induce a posterior vitreous detachment. We stain the posterior pole with a blue dye known as brilliant blue green to identify the macular hole. Now the point here is there is a lot of chorioretinal patchy and diffuse beneath the retina. So the contrast is very poor as compared to the emmetropic eyes. So the ILM peeling is very difficult, but we gradually, slowly, meticulously peel all the ILM around it. You can see these blue flaps. These are ILM flaps. So once one flap is there, you can see there's a lot of contrast. Then the thing becomes easy. These are the clump of ILM flaps over the macular hole. Now, what we do is we reposition these clumps with the help of a heavy liquid, which is known as perfluorocarbon liquid, PFCL. So we have injected a small bubble of PFCL so that all these clumps which we made are stuffed into that hole. Finally, we go under air, aspirate the PFCL, inject oil, silicone oil or gas to end the surgery. So, to conclude, this is a huge burden, even if it is 3% of the population, but by the rate which myopia pandemic is growing, it is a significant disease burden affecting especially young individuals in their prime economic days. And fortunately, modern anti-VEGFs and improved surgical techniques like vitrectomy, macular buckles have proven revolutionary in the things we can treat, like retinal detachment, like macular holes, like myopic CNVMs. But the ultimate goal is to suppress myopia progression. So these things do not happen, like staphyloma, the atrophy, whether it is diffuse or patchy choroidal atrophy. We do not have any treatment for that. And that can be only achieved with the suppression of the myopia at the myopic or the high myopic stage. So there are modifiable factors which we know, that is to increase outdoor activity in children, which is considered to suppress progression, and low dose atropine therapy, which has found to be, in the ATOM study, to be effective in progression, peripheral defocus classes, orthokeratology, but no definite treatment has come still to suppress or to halt myopia at the early stage. Of course, gene therapy targeting specifically pathological myopia or also in research phase. Finally, for postgraduates, I would just like to make a small comment that these eyes are diseased eyes, and these eyes, these patients are totally at the mercy of your examination. So, you have to give more time. A normal fundus examination or normal indirect might not take much more time, and it can be forgiving. But for pathological myopia, you have to give double the time because these are difficult to examine. Also, you have to see the periphery, you have to see the posterior pole, because these eyes have both pathologies at the macula also and at the periphery also. You cannot miss the lattice, you cannot miss a myopic CNVM, you cannot miss a hole, because these will progress. And even if the macula does not detach, the myopic CNV might cause a atrophy and cause a permanent scar. If the clinical examination is doubtful or difficult, as it will be in the hands even of the most astute clinicians, you take the help of modern investigations, a simple investigation like a OCT or FFA, to diagnose these pathology and treat or refer it to the person who is qualified to treat these complex eyes. Thank you so much, and be happy to take any questions, any doubts from the students. Kunita.
Yes, thank you so much, sir, for that elaborate lecture on degenerative myopia. I think it is one of the most common things that, not the most common thing, but something very important that residents keep seeing in the OPD, patients of myopia and degenerative myopia, good screening, peripheral screening, as you have rightly said, a proper chair time and to do a proper screening is something very crucial in the management of these patients. And thank you, sir, for that elaborate lecture and all the topics, all the aspects that have been very well covered and all the complications that these patients face. So, sir, there are just few questions that have come up. One of the resident has asked that how frequently should we screen these patients for a patient of pathological myopia that has come to my OPD?
So, pathological myopia follow-ups have not been defined per se, but there are few things which can prompt you for an early follow-up or an early screening also. So, if the patient is a uniocular patient, the other eye has been lost to a retinal detachment or a myopic CNVM. If there is a family history of retinal detachment, they have to be more closely followed up. If they do not have any offensive lesion, you might follow up them every 3 months or 6 months. If they have a offensive lesion or they are under treatment with anti-VEGFs or you have lasered a lattice, they might mandate a monthly follow-up also.
Okay.
And you should always explain to the patient also, if the patient is not from your city and is coming from a distant town where facilities of fundus examination are not there, you should clearly explain the signs and symptoms of metamorphopsia, of central vision loss, a curtain falling over the eye, which are very common things which you explain to every myope patient. The sign and symptoms of retinal detachment, the sign and symptoms of myopic CNVMs. These two are the most common and the most commonly treatable lesions in pathological myopia.
So, do you give an AMSLR grid to even patients of pathological myopia?
I don't think AMSA grid works in such poor visual acuities. Actually, it is more meant for patient having good visual acuity of 612, 618 minimum. So if they have a posterior staphyloma, very poor vision, finger counting, then AMSA grids will not help. But of course, it's a good idea if the patients are in the diffuse chorioretinal atrophy stage with good vision, AMSA grid monitoring can be given to them.
So another resident has asked a question. Should indentation be done in all the cases of pathological myopia?
Very good question. Actually, indentation as a postgraduate should be done if you are told to screen the periphery. But of course, there are no shortcuts to indirect. But what is commonly seen during surgery also and during examination also, you can visualize the aura in pathological myopias without indentation also. So that is a very convenient thing to do. So you don't need to indent in every case. If you see the aura with a slight tilt of your head and the patient in supine position, you don't need to put him into discomfort of indentation. And similarly, as I said, in surgery also, when we go under air or while we are doing our vitrectomy, without indentation by the assistant, we can see the aura and we can do a peripheral laser very well as compared to emetropic eyes.
Just to add, I hope I'm
Yes, sir, you're audible and
Yes.
visible. So you're audible and visible both? Okay, so
Oh,
there
you
is
were saying
another
something?
question so there's another question in the meanwhile, we'll just take that. So they're saying,
Yeah.
resident has asked if the laser has been done, if a laser has been done in a patient who's planned for cataract or refractive surgery, how much time should one wait before proceeding for surgery?
So again, the chorioretinal adhesion, when you do a laser, generally develops in 10 to 12 days. So it's a safe to be on the safer side. A safe margin of 2 weeks before refractive surgery or cataract surgery is good enough. You can perform the procedure, whether it's a LASIK, whether it's a femto, whether it's a cataract, after 2 weeks of laser of the lattice barrage. Of course, I will be waiting a little longer in tractional holes like horseshoe tears, maybe a month or 2 months to see any fluid progression or any tear progression or formation of new tears. But for simple lattices, I think 2 weeks is safe, and you can proceed with the other surgeries.
So one last question that I have from one of the resident is saying he's saying that should OCT be done in all cases of pathological myopia to rule out CNVM and macular
100%, very good. Even if the vision is good, you should mandate in your OPD protocol after indirect. If you have a SGOCT in your clinic, even the best of eyes, because of the poor contrast, because of the high visibility of the choroidal vessels, you can miss choroidal neovascular membranes, especially small membranes. you should do OCT for pathological myopia. There is no shortcut to it.
Thank you, sir. I think these are the questions that I have. If Praful sir would like to make few comments.
Just highlighting one point where you asked, no, if routine indentation is mandatory in all cases. I just like to share one of my experience. Even I hope sir could recall at RPs, we used to have a IO posting where
Yeah.
you all the patient referred from OPD. So there was a patient of -3 diopter, and I was just I think Dr. Naginder was my SR, and I just asked him, ki, should I indent? Then he said me, ki, why you are asking this question? I told him because it's just -3 diopter. Then he told me that ki, no, even if it is -2, you should screen the retina. And that patient had two HSTs in periphery. So the important point is even if you don't have an indenter, at least with extreme gauges, you should screen the periphery of retina. In any case of pathological myopia, irrespective of the myopia grade. I hope I am right, sir.
Exactly. Praful, the whole point, what you're saying is absolutely correct. The whole point is whether you are indenting or whether you're not indenting. The whole point is that you do not miss a lesion near the aura. So if the aura is visible without indentation, like in pathological myopia in some cases, or with indentation, if you are seeing the aura and you are finding no lesion, then the patient is safe. You should not miss any lesion in the far periphery. That is the whole point.
Perfect, sir, and wonderful lecture, sir. And I think you covered almost everything, every aspect of myopia, which is the essence of our postgraduate education program. And just to inform you, we have almost 810 students. Few of
Wow.
them are watching live, and few of them will watch subsequently in our YouTube channel. And this is a small appreciation from DOS. And I would like to invite you to our annual DOS, sir, on 13, 14, 15 June, and which we are trying our best to do it at Bharat Mandapam.
Wow. Very nice.
And
All the best for your future lectures and future program. Thank you so
thank
much.
you so much, sir. If you join us, no, then we'll give you a frame certificate. That is the incentive that I'm offering to you.
Hope to see you soon. Thank you so much. Thank you.
Thank you, sir.
Bye.
Pranita, you can conclude.
Thank you, Vishal sir, for your valuable and precious time and for all the effort in making the presentation and putting in all the points together for all the residents, which is absolutely bang on to the point and important and relevant for their exams as well. And thank you, Praful sir, for joining us. With that, we'd like to come to an end of this class. And our next class is on CNVM, and which will be taken by Dr. Sanjay Mishra sir. So please join in to all the students. It's a request. Please join in for the next class as well. And with that, we'd like to say good night. Thank you.